Welcome to the Rad-On Smart Review Head Neck Cancer series.
It is great to be back.
Today we are tackling a massive topic. This is episode 28, Organ Preservation, the Landmark Trials.
Yeah, this is one of those topics that, it really defines our field. It's the story of how we moved from a surgery-first paradigm to a radiation-dominant one.
And it also covers the lessons we learned, sometimes the hard way, about what it actually means to save an organ.
Exactly. And when you say the hard way, that's no exaggeration. We're going to look at the trials that built our standards of care, but we're also going to look at the data that, frankly, haunts us a little bit.
The late toxicities.
The late toxicities, the failures. Because, understanding the failures is maybe even more important than just memorizing the successes for your boards.
I agree completely. This isn't just about celebrating radiation oncology. It's about being honest about the cost of our victories, the trade-offs involved in giving high-dose chemoradiation. So before we get into the trials themselves, we really have to set the stage. Let's look at the historical context. If you were practicing before, say, 1991, treating advanced laryngeal cancer was incredibly straightforward.
Straightforward but brutal. That's the key word.
The standard of care was a total laryngectomy, followed by postoperative radiation. That was it. That was the algorithm. You see a tumor in the larynx, you take it out.
And to be fair, from a purely oncologic perspective, it worked really well.
Oh, absolutely.
The local control rates were fantastic. I mean, patients survived the cancer. Surgeons got very, very good at this. The recurrence rates at the primary site were incredibly low, mostly because the primary site was in a jar in pathology.
Right. But that trade-off was immense. We're talking about the total loss of the voice box.
It is a life-altering surgery. Patients survived, yes, but they lost their natural voice. They lost the ability to breathe through their nose and mouth.
They needed a permanent stoma in their neck.
A permanent stoma. They lost the ability to Valsalva, which, people don't think about. But that affects everything from lifting heavy objects to having a bowel movement.
And the psychosocial impact of that.
Oh, it was devastating. Quality of life studies from that era, they consistently showed these patients had worse emotional function, much higher rates of depression, and, significant social isolation. The stigma of the stoma, the altered speech, it just changes how you exist in the world.
So the field was desperate for an alternative. And that really brings us to the paradigm shift, the one central question that changed everything.
Which was?
Can we achieve equivalent survival while preserving the larynx?
And the answer, which we'll establish today through these trials, was a resounding yes. But, and this is the huge but we're going to hammer home today.
A very big but.
Only for the right patients.
And with the right approach. Because, as we're going to get into, long-term follow-ups show that the very treatment which best preserves the larynx might come with late toxicity issues that actually hurt survival a decade later.
It's the classic radiation oncology story, isn't it? You solve one problem, like local control, only to discover a new challenge, like late fibrosis and aspiration years down the line. We cure the cancer, but we might create a chronic disease of the pharynx.
So our mission today is to really dissect the big three trials. We're going to look at VA Larynx, RTOG 9111, and GORTEC 2001.
And the goal here is to teach you how to interpret these for your oral boards and, more importantly, for your clinic. You have to move beyond just memorizing the abstract and really understand the nuances of patient selection. When to quote the trial, and just as important, when to know it doesn't apply.
Okay, let's jump in. We'll ground this whole discussion with a case anchor. This is a patient you could easily see tomorrow.
Perfect. Let's hear it.
We have a 62-year-old man. He's a heavy smoker, a 40-pack year history, presents with 3 months of progressive hoarseness and some mild dysphagia.
Okay, when you say dysphagia, is he choking on food? Is he losing weight? Stridor?
No stridor, no significant weight loss yet. He's still eating, but he says it's difficult. Describes a catch in his throat. So on his flexible laryngoscopy, his MPL, we see a large exophytic mass. It's on the left aortoglottic fold, and it extends down to the left false cord and the true vocal cord.
And the mobility, that's the million-dollar question, always.
Crucially, the left cord is fixed, the right cord moves normally.
Okay, a fixed cord. That is a key staging detail. That immediately puts us into a specific T stage.
Right. Moving on to imaging. The CT of the neck shows the primary tumor. It possibly abuts the thyroid cartilage, but there's no definite through-and-through invasion. The cartilage looks intact, but the tumor's right up on it. And there's also a 2.5-centimeter node in left level 2.
And the PET CT.
The PET CT confirms an avid primary and avid nodal disease in that level 2 node. And importantly, no distant metastasis. Biopsy comes back. Moderately differentiated squamous cell carcinoma, SCC.
Okay, let's stage this together before we go on. We have a fixed chord. In the laryngeal staging system, vocal cord fixation defines a T3.
Exactly. If it were just impaired mobility, that's a T2. But fixation makes it a T3.
Right. And it's important to understand why. Fixation usually implies deep invasion into the thyroidenoid muscle or maybe the cricoretinoid joint. It's a sign of deep infiltration.
So T3. And we have a single ipsilateral node, less than 3 centimeters.
That's N1.
No Mets, so M0. This is a stage 3 supraglottic SCC.
Stage 3. Historically, this is a patient who's going straight to the OR.
So here's the consult question that hits your desk. Is this patient a candidate for larynx preservation? And if so, what's the optimal approach?
Okay, before we even touch the trials to answer that, we have to define our terms. We have to define what success actually looks like. We need sort of a ruler to measure these trials against.
I love that analogy, the ruler.
Because if we use the wrong ruler, we might think we're winning when, in fact, we're actually losing for the patient.
You're so right. Preservation can mean a lot of different things depending on who you ask. A surgeon sees it one way, a radiation oncologist another, and the patient.
Yeah.
They probably define it completely differently from both of us.
Exactly. So when you talk about larynx preservation on your oral boards, the examiners are going to probe you on this. They want to know if you get the nuance. There are really 3 different endpoints, 3 different markings on this ruler.
Okay, let's break them down. Endpoint 1, larynx preservation rate.
This is the most basic, most simple definition. It just means the larynx was not surgically removed. The patient, dies with their thyroid cartilage still in their neck.
So anatomically, it's there.
Correct. But here's the huge flaw. This endpoint includes completely non-functional larynxes. So if a patient has chronic aspiration, if they are 100% dependent on a PEG tube for nutrition, if they need a tracheostomy to breathe because the airway is scarred shut, they technically have a preserved larynx by this definition.
Is that a success? I mean, really?
I would argue it's a failure. It's a biological burden. It's a useless organ that is actively causing harm, a source of infection, pain, misery.
Okay, that leads us to a better metric. Endpoint 2, laryngectomy-free survival, or LFS.
Right. This is a composite endpoint. It means the patient is both alive, AA, they still have their larynx. It tries to capture that trade-off between survival and keeping the organ. You'll see LFS a lot in these trials.
But again, does it tell us if the organ actually works?
It does not. You can be alive with a useless aspirated stenotic larynx and still count as a success for laryngectomy-free survival. It tells you about the anatomy and the heartbeat, but not the function.
Which brings us to the holy grail, endpoint 3, functional larynx.
Yeah.
Sometimes you see it called dysfunction-free survival.
This is the endpoint that actually matters for quality of life. This means the larynx is preserved and it is functional. The patient can swallow food, they can breathe without a track, and they can communicate effectively.
This is the board pearl right here.
100%. You have to be able to say this explicitly. The goal is not just to preserve the larynx. It's to preserve a functional larynx. A preserved but non-functional larynx is not a treatment success. If you save the organ but you destroy the function, you have failed that patient.
So keep that ruler in mind as we go through the data. You'll see the early trials focused on anatomy, and the later analyses really had to pivot to function. Let's start with the first landmark, the VA Larynx trial, NEJM 1991.
This was the trial that broke the mold. It was the one that dared to challenge the surgical dogma. The question was pretty simple. Can induction chemotherapy plus radiation achieve equivalent survival to a total laryngectomy plus post-op radiation?
I mean, think about how audacious this was at the time. You're asking patients to forego the only known cure surgery for an experimental chemo and radiation approach.
It was a massive gamble. So let's look at the design. They took 332 patients, stage 3 and 4 disease.
And this is a high-risk group. 63% had supraglottic tumors, 57% had cord fixation. These weren't small, easy cancers. These were big, bulky tumors that everyone at the time thought needed a scalpel.
Right, so they randomized them to 2 arms. Arm A was the standard, total laryngectomy plus a port, which means post-operative radiation.
The control arm, standard surgery, probably followed by 50 to 70 gray.
And arm B was the experimental arm, induction chemotherapy followed by radiation.
And the regimen was the classic PF regimen. Cisplatin 100 milligrams per meter squared and 5-FU 1,000 milligrams per meter squared, given as a continuous infusion.
Now, here's the innovation, and this is the part of the VA trial that I think gets misunderstood the most. It wasn't just give chemo and radiate everyone, it was response-adapted selection.
This is the most critical piece. They assess the response after just 2 cycles, not 3, not at the end of chemo. After 2 cycles, they did a laryngoscopy and reassessed the tumor.
And why 2 cycles? Because if you haven't seen a significant response by then, you're just wasting valuable time. You have to pivot.
So what happened at that checkpoint?
If the patient had a complete response, a CR, or a partial response, a PR, they went on to get definitive radiation, and this was the majority, about 85% of the induction group. They proved their tumor was sensitive.
And if they didn't respond, the other 15%.
If they had less than a partial response, they went directly to laryngectomy. They did not pass go. They did not get radiation. They went straight to the OR.
So the key takeaway isn't that the chemo was magic. It's that they used the chemotherapy as a selection tool.
Precisely. It was a biological litmus test. If the tumor was sensitive to platinum, it was highly likely to be sensitive to radiation. If it grew through platinum, radiation alone probably wasn't going to cut it, so you go to surgery immediately and don't delay the definitive treatment.
It's essentially in vivo sensitivity testing.
Exactly what it is.
Okay, so let's get to the results. Did it work?
The headline number, the one that changed everything, was survival. 2-year overall survival was 68% for the surgery arm and 68% for the induction arm.
Equivalent survival, that was the victory.
That was it. It proved you didn't have to remove the voice box to save the person's life. And in the preservation arm, 64% of patients kept their larynx. That's 2/3 of patients who avoided that brutal surgery.
What about the patterns of failure? Did the radiation arm fail more often locally?
It did, and that makes sense. The preservation arm had a higher local failure rate, 12% versus only 2% for surgery. I mean, if you cut the tumor out, it's hard for it to grow back in the exact same spot.
But what about distant mets?
That's where induction had an advantage. The induction arm had lower distant metastases, 11% versus 17%. The p-value was significant. The systemic therapy was likely cleaning up micrometastatic disease that was already circulating.
Okay, but there was one group that really did not do well with this approach.
Yes, the T4 problem.
Tell me about it.
In this trial, 56% of the T4 patients ultimately required a salvage laryngectomy. Compare that to the T2 and T3 patients, where only about 25 to 29% needed salvage.
That is a massive difference. Why do T4s fail preservation so often?
It's probably the biology of cartilage invasion. When a tumor invades cartilage, it chokes off the blood supply. Cartilage is already pretty avascular.
Right.
So the chemo drugs and the oxygen, which you need for radiation to work well, they just can't penetrate that necrotic, invaded cartilage effectively.
The tumor finds a sanctuary inside the cartilage.
Exactly. It hides there. And this finding directly led to the exclusion of large volume T4 tumors in all the later trials. We learned that T4 disease, with that gross cartilage invasion, is just a different beast. It's often best treated with surgery.
So VA Larynx proves preservation is possible without hurting survival. But of course, science moves on. We start asking, well, is induction the best way? Or is giving the treatment concurrently better?
And that brings us to RTOG 9111, published in the NEJM in 2003, and then the crucial long-term update in JCO in 2013. This is, arguably the most important trial in this whole space.
The question here was, among all the non-surgical options, which one is the best? We know we can save the larynx, but what's the best recipe? Induction versus concurrent versus radiation alone.
Right. They randomized 547 patients, again, mostly supraglottic, but look at the exclusions. They specifically excluded large volume T4 disease.
Applying the lesson from the VA trial.
Exactly. No tumor invading more than 1 centimeter into the base of tongue, no penetrating the thyroid cartilage. They knew those patients would do poorly, so they took them out to get a clean signal on the regimens themselves.
So let's break down the 3 arms. All patients got 70 gray of radiation.
Right. Arm 1 was radiation alone. 70 gray, no chemo. This was the control. We often forget radiation by itself cures a decent number of this hoax.
Arm 2 was induction PF, followed by radiation, basically the VA regimen.
Same strategy. Give induction, see who responds, then radiate.
In Arm 3, the new challenger was concurrent chemoradiation with high-dose cisplatin.
Yes. Cisplatin 100 milligrams per meter squared on days 1, 22, and 43, given during the radiation. This is the heavy hitter.
Why those specific days? 1, 22, 43.
It's every 3 weeks. This schedule provides a very high peak concentration of the platinum, which acts as a potent radiosensitizer. It gets in there and inhibits DNA repair in the cancer cells right when the radiation is causing the damage.
Okay, let's talk about the initial results from 2003. This is what established the standard of care for a decade.
In 2003, the results were crystal clear. Concurrent chemoradiation was superior for larynx preservation. The rate was 88%.
88%. That's a huge number.
It's massive, compared to 75% for induction and 70% for RT alone. And local regional control was also best in the concurrent arm at 78%. It was just the most effective way to kill cancer in the head and neck.
And survival at that time point.
Survival was equivalent across all three arms, hovering around 75% at 2 years.
So based on this, concurrent CRT became the NCCN standard. It saved the most larynxes, it controlled the neck the best. It really seemed like the obvious winner.
Case closed, right? We found our winner.
Not so fast. In 2013, the 10-year data came out, and there was a plot twist that I think nobody really saw coming.
A major plot twist. So 10 years out, larynx preservation was still the best in the concurrent arm. It held up. It was 82%.
But the survival.
This is where it gets scary. Overall survival at 10 years showed a trend where the concurrent arm was actually the worst. 28% survival for concurrent versus 39% for induction.
Wait a second. The treatment that controlled the cancer the best resulted in the worst long-term survival.
Well,
Was it cancer recurrence that was killing them?
no. And that's the thing. Deaths not attributed to cancer were significantly higher in the concurrent arm, 31%, compared to about 17% in the radiation alone arm.
So they were dying of other things. What's the interpretation? What is killing these patients if it's not the cancer?
The prevailing hypothesis, and this is the board-safe language you want to use, is that this signal represents late toxicity, specifically late swallowing dysfunction leading to chronic aspiration and aspiration pneumonia.
So we effectively damaged the swallowing mechanism so much that the preserved larynx became a liability.
Exactly. It became a silent killer. Concurrent cisplatin and 70 gray of radiation creates intense fibrosis. The pharyngeal constrictor muscles, they become stiff. The larynx doesn't elevate properly during a swallow.
So food and saliva just trickle into the airway.
Causing repeated low-grade pneumonias, and eventually one of those pneumonias is fatal.
Wow. That's a really sobering realization. We saved the organ, but we might have sacrificed the patient's long-term health to do it.
It forces us to go back to our ruler. It highlights that huge difference between anatomic preservation and functional preservation. If the organ is there but it's killing the patient, that is not a success.
So how do we synthesize this for the boards? Because we still use concurrent chemoradiation every single day.
You have to present a balanced view, you say. Concurrent cisplatin RT is the most effective regimen for preserving the larynx, but preserving a functional larynx requires rigorous patient selection, lifelong swallowing surveillance, and a readiness to pivot to surgery if that larynx becomes dysfunctional.
It's all about vigilance.
Constant vigilance. You can't just treat them, pat them on the back at 5 years and say you're done. You have to watch them forever.
Before we move on to how we apply all this, there's one more trial we need to cover. GORTEC 2001.
Right. This trial asked a more specific chemotherapy question. It acknowledges that sometimes we do use induction. So if we are going to use induction, is the old doublet PF good enough? Or do we need the triplet TPF?
Adding a taxane to the mix.
Exactly. Docetaxel, cisplatin, and 5-FU versus just cisplatin and 5-FU.
What do they find?
TPF was the clear winner. The response rate was higher, 80% versus 59%. But look at the 10-year larynx preservation. It was 70% with TPF versus only 47% with PF.
That's a massive difference. Adding the taxane almost doubled the long-term success of keeping the larynx.
And crucially, they reported that functional endpoint we keep talking about, dysfunction-free survival. At 10 years, it was 64% for TPF versus 37% for PF.
So the practice point here is pretty simple. If you choose to use induction, TPF is the regimen.
Correct. PF induction is obsolete. If you're doing induction for laryngeal cancer, you use the triplet. The taxane just adds significant activity against squamous cell carcinoma.
Okay, so we have the data. VA says preservation is possible. 9111 says concurrent is best for preservation, but warns us about toxicity. GORTEC says if you do induction, use TPF. Let's talk clinical decision-making.
This is where the rubber meets the road. I would say the default setting in your clinic for a good candidate should be concurrent cisplatin RT. This is based on the superior preservation rates we saw in RTOG 9111.
But are there times when we should use induction? Because that 9111 data did suggest a potential long-term survival benefit.
Yes, but it's for a very specific list of indications. It's not for everyone. You don't just give induction because you're vaguely worried about toxicity. You give it for clear reasons.
Okay, give me that list. When do you use induction?
Number 1, symptom relief or airway compromise. If you have a massive, bulky tumor that's threatening the airway, induction can debulk it rapidly. You can shrink it down to make the airway safe before you start 7 weeks of radiation. It's like a chemical debulking.
Makes sense. Number 2.
Bulky disease with a high risk of distant metastases. We saw in the VA trial that induction reduced distant mets. So if you have N2 or N3 disease, lots of nodes, big nodes, bilateral nodes, you're worried about systemic spread. Giving systemic therapy up front makes sense to try and sterilize the rest of the body.
And number 3.
Chemo response selection. This is the VA logic. If you're really on the fence about whether a patient is a true responder, maybe they have a borderline T4 tumor, you can use induction as a test. Give it, see if it shrinks. If yes, radiate. If no, you pivot to surgery. It's a biological test drive.
And the final reason.
Patients who are just unable to tolerate concurrent high-dose cisplatin, maybe they have baseline renal issues or hearing loss, but you have to go into that acknowledging you might be trading off some degree of locoregional control.
I'm going to quickly mention the Paradigm, Decide, and the Spanish trials. We hear these names thrown around.
Right. Briefly dismiss them. Those trials ask a different question. They ask, should we do induction followed by concurrent chemoradiation? They tried to stack everything on top of everything. The answer was no. It just added toxicity without any benefit. But don't conflate that with VA or 9111, which compared induction followed by radiation alone. It's a different question.
Good clarification. Now let's get real about the toxicity. We mentioned the late deaths in 9111. Let's dig into the data from McTay and Ward. This is the stuff that should keep us all up at night.
This is the reality check. So McTay published in JCO in 2008. He pooled a bunch of data to look for what he called severe late toxicity.
And how is that defined?
It was grade 3 or 4 toxicity that happened more than 180 days after treatment. Things like feeding tube dependence for more than 2 years, or death due to laryngeal dysfunction like aspiration pneumonia.
What were the biggest risk factors? Who is most at risk for this?
Age greater than 70. We know older patients just don't tolerate concurrent chemo as well. Their functional reserve is lower. T4 disease big tumors that destroy the anatomy before we even start. And unsurprisingly, a larynx primary site. The larynx is just a very complex, delicate organ. If you blast it with high-dose therapy, it breaks.
And the Ward paper from Oral Oncology in 2016?
This is truly frightening data. They followed patients who were eligible for 9111 long-term. 27% had severe late dysphagia at 5 years.
27%. That's more than 1 in 4 patients.
And here's the kicker. 3 out of 5 aspiration admissions and 5 out of 8 late feeding tube insertions happened after the 5-year mark.
So this toxicity, it isn't just acute. It isn't just, oh, I have a sore throat during radiation. This can happen 5, 7, 10 years later.
Exactly. The fibrosis is a progressive process. The tissues get stiffer and stiffer over time. The pharyngeal constrictors, they turn into leather. The larynx becomes a rigid tube that can't close properly. The epiglottis gets stiff and doesn't flip over. It's this progressive stiffening of the whole swallowing apparatus.
How does this change our clinic workflow? Because if this is happening 10 years out, we have to be there to catch it.
Number 1, a baseline swallow evaluation is mandatory. You have to know what you're starting with. If they're already aspirating before you start treatment, you need to know that. It helps manage expectations.
Okay, number 2.
Early speech-language pathology involvement. SLP before, during, and after treatment. The whole use it or lose it mantra with swallowing exercises is real. We have to keep those muscles moving to prevent them from freezing up.
And number 3?
Long-term surveillance. Do not discharge these patients at year 5. You need to keep asking them about coughing when they eat, about pneumonia, about weight loss forever.
And finally, that readiness to pivot we talked about.
Right. If the larynx becomes a useless organ, causing chronic aspiration recurrent pneumonias, you have to be willing to recommend a laryngectomy for a dysfunctional larynx, even if there's no cancer recurrence. You're saving them from the complications. Sounds radical, but sometimes removing the organ is the best palliation you can offer.
So let's try to frame patient selection, because clearly not everyone should get preservation. Who do we say no to?
The single most important factor is the functional baseline. You have to ask yourself, can this patient swallow and breathe adequately right now?
And if the answer is no,
If the larynx is already non-functional, if they're already tract-dependent and PEG-dependent because of the tumor, then preservation is futile. You are just preserving a non-functional organ. They're going to have a terrible quality of life. In that case, surgery is often the better, kinder option.
what are the hard exclusions? I'm thinking of the Beitler criteria.
Right, Dr. Beitler is very clear on this. Greater than 1 centimeter of base of tongue invasion. Why? Because the functional outcome is abysmal. If you have to radiate the entire base of tongue to 70 gray, they won't swallow well. The base of tongue provides that driving force for the swallow. If you fibrose it, they can't push food down.
Cartilage penetration.
Through and through cartilage invasion. That's a T4A indication for surgery. These tumors just don't respond as well to radiation, and the cartilage often necroses after treatment.
And what about social factors, like smoking?
Persistent smokers have poor outcomes, and you need good social support and compliance. This treatment is a marathon daily radiation chemo appointments, SLP exercises. If a patient can't commit to that intensive regimen, surgery is often the safer, more reliable path to a cure.
We have to mention salvage, too. If preservation fails, can't we just do surgery later?
You can, but is not the same operation. A salvage laryngectomy is much, much harder than an upfront one. The tissues are radiated, they're fibrotic, the blood supply is poor.
So healing is a major issue.
Huge issue. The fistula rate goes from almost 0 to 20 or 30%, and cure comes first. Salvage isn't always successful. In 9111, about a quarter of the local failures were not salvageable. Those patients lost their only chance at cure. You have to get it right the first time.
Okay, let's bring it back to our case. 62-year-old male, T3N1, fixed cord. His functional baseline is good, he's still swallowing, and no definitive cartilage invasion.
This is the sweet spot. He's a very reasonable candidate for preservation. He fits the criteria.
So what's your treatment plan?
I would treat him with concurrent cisplatin and radiation.
Give me the numbers. The dose.
The radiation dose would be 70 gray in 35 fractions to the primary tumor and the involved node. Then 54 to 56 gray to the elective nodal regions.
And the chemo.
Cisplatin 100 milligrams per meter squared on days 1, 22, and 43.
And the supportive care.
A baseline swallow evil with SLP on board from day 1. I'd only place a PEG tube if he demonstrates significant weight loss or aspiration risk during treatment. And then very close lifelong surveillance.
How do you counsel him? Give me the script.
Yeah.
You have to warn him about all these long-term risks we've discussed.
I'd sit him down and say something like this. Look, based on the best evidence we have, this aggressive treatment gives you a very high chance, about 80% or so, of keeping your voice box while curing the cancer. However, this is an intensive treatment. There's a real risk that even if we cure the cancer, your voice box might be stiff or not work perfectly down the road. We will need to monitor your swallowing for the rest of your life. And if the cancer comes back, or if the voice box stops working and starts causing infections, we might still need to recommend surgery later. But right now, this is our best shot at a cure with preservation.
Clear, honest, and evidence-based. You're not promising a perfect outcome, you're promising the best shot.
Exactly. It's all about managing expectations from the very beginning.
All right, are you ready for a board blitz?
Let's do it.
Okay, I'll pose the question. You give me the answer and the rationale.
I'm ready.
Question 1. Scenario. A 58-year-old male with a T3N1 glottic cancer is considering preservation. Based on RTOG 9111, which arm had the highest 10-year larynx preservation rate?
The answer is the concurrent chemoradiation arm.
What was the percentage?
82%.
Rationale.
Concurrent treatment provides the best local control and therefore prevents laryngectomy more effectively than induction or radiation alone. The trap here is not to confuse preservation with survival, where the concurrent arm actually trended lower due to late toxicity.
Perfect. Question 2. Scenario. In the VA Larynx trial, when was the crucial response assessment performed to decide if a patient would proceed to radiation?
After cycle 2 of induction chemotherapy.
Rationale.
This was the response-adapted selection point. It was an early check on tumor biology. If the tumor didn't respond by cycle 2, the patient was triaged to surgery immediately.
Excellent. Final question. Scenario. What was the most concerning finding from the RTOG 9111 10-year follow-up update?
The non-cancer death rate was significantly higher in the concurrent chemoradiation arm.
Rationale.
It was a 31% non-cancer death rate versus about 17% in the radiation alone arm. This is the big signal for late toxicity, most likely from aspiration and severe swallowing dysfunction.
Excellent. That covers the
Those
blips.
are some very high yield points.
Okay, let's wrap this up with a summary of our clinical pearls.
Pearl number 1. The VA Larynx trial proved that organ preservation was possible without compromising survival, and its key innovation was that response-adapted selection.
Pearl number 2. RTOG 9111 established concurrent CRT as the standard of care because it had the best larynx preservation rates and the best local regional control.
Pearl number 3. But that same trial gave us a major warning at 10 years. Concurrent treatment carries a significant risk of late non-cancer death. We have to be vigilant about long-term toxicity.
Pearl number 4. If you are going to use induction, say for a massive tumor that needs debulking GORTEC, 2001 tells us to use TPF, not PF.
Pearl number 5. Always remember the ruler. Preservation does not equal function. A non-functional larynx is a burden, not a success.
And finally, Pearl 6. Surveillance for these patients must be lifelong. Swallowing issues can and do arise 5, 10, even 15 years down the road.
Keep looking, keep asking the right questions, and keep your SLP colleagues close.
This sets the stage perfectly for our next discussion. Next time, we're going to look at the patients who fall outside of these preservation criteria.
That's right. Episode 29, Advanced Larynx, T4A and the Unpreservable. We'll be talking about when to say no to radiation and yes to the scalpel.
Complete practice oral boards at radongsmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.
Thanks for tuning in.